Going to be doing a Deuk laser disc repair, lumbar, bilateral L4-5, left side L3-4. Our patient has traveled from Jacksonville, Florida. Huh? And he's suffering with 50% back pain and 50% leg pain, or he has neurogenic claudication as well. He's got herniated discs pretty much at every level in his back. However, the ones that I think are causing his symptoms are L3-4 left side and L4-5 bilateral. So we're going to get started. If you're looking at his x-ray, he has some scoliosis as well. We're not fixing scoliosis today. Scoliosis fixing surgery requires an open surgery with osteotomies and screws and rods and stuff like that, which is what we're trying to avoid. But we're going to be fixing herniated discs that are impinging on nerve roots, irritating nerve roots, causing leg symptoms. Our patient has foraminal stenosis, secondary to disc herniations, and that's what we're going to target. Okay? So we're going to get started. Sir? It's Dr. Deuk Majin. Can you hear me? I'm just touching your back, okay? What we're going to do here is we're going to keep you awake for about 5 or 10 minutes, probably 10 minutes more likely, maybe even up to 15, while I get things in place, okay? I need your help and I need you awake. Once we've got everything set, we're ready to do the surgery part, we're going to put you to sleep. So you'll be asleep for the surgery part. All right. Now, as I'm getting you prepared and ready for surgery, I'm going to be injecting some numbing medicine in your skin. You're going to feel that as a little pinch and a burn. That's normal, okay? If you feel any more pain than that, you need to let me know. Just say, ouch. It's important that it's just your lips that move and not your back. So I'm going to ask you to get comfortable right now on the bed. Is there anything we can do to make you more comfortable? Yeah. Sir? Yeah. Okay. Then I'm going to get started, and I'm just going to ask that you lay still, okay? Don't try to get up and move around. Again, if it feels uncomfortable, just say ouch, and I'll give you some more medicine. All right, so the first thing we're going to do is, he's a pretty muscular gentleman, so we're going to go ahead and, that's the stick I was talking about, okay? And that's the burn. And remember, we're doing left 3-4, left 4-5, and right 4-5. I wish I could see. And I'm going to do the other side now, okay? So you'll feel a little stick and burn there as well. That's all normal. All right, sir. We are going to get started. You have any questions for me, sir? All right. AP? I see. All right. So that's 4-5 down there with all the scoliosis, Dr. Patel? Let me know if it's uncomfortable, okay? Shot. You're going to hear me talking to my team as we go along here. So obviously, Dr. Patel, scoliosis makes the surgery more complicated. Is that our shot? All right. Shot. May have to start lower. Shot. Let's get a lateral, please. It looks like 3, 4, and 4, 5 kind of shift their plane, right? One points down on our side, the other one almost points up. So we might have to do 2 separate incisions for 3, 4, 4, 5. Let's line up 4, 5 discs, please. End plates. I know it's hard. You can kind of see the shadows of the iliac crest, so that could help you. Yeah, that's right. I think you need to go that way. Let's try more. Bring your base north, north, north. You need more. And bring your base more north. There you go. And now swing my side south. More. Keep going. Swing, swing. That's better. Keep going. That's almost good. That's good. That's good right there. Lock it down, please. All right. So, being able to do the surgery means you have to be an expert at reading x-rays. Shot? Because there's nobody that's going to do it for you. That's not it. There you go. Shot? I'm aiming for that 4-5 disc space. For those of you wondering. Shot? So I'm right in the facets right now. Shot? 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 Are you having any issues with the floor, or is it working pretty good? Shot? Why? Shot? Why? You're having delay?
No, the button was just sticking.
Oh, okay. That's it right there? Yeah. All right. I didn't know if you're having like a neurological delay.
Oh, that could be too.
A little postprandial, like, lethargy. Shot. Or there's an electrical shot delay. It's a little higher than I want to be. Shot. Sir, how are you doing, Shot? Good. Any discomfort yet? AP? A little what? A poke in the left thigh? Is it left side on your back or in your thigh? Thank you. Yeah, that's fine. That's perfect. I'm very happy. Yeah, let's go back to a lateral. So obviously, for those of you watching the surgery, it would be nice if the spine was straight and not rotated, or, just easy. But the truth is that when people have disc problems, it's like having a flat tire on one side. Your car is going to shift, and it's no longer going to be, no longer going to be parallel to the surface. It's going to be off to the side. So I'm accustomed to dealing with these issues. Shot? So I can feel we're entering the disc herniation. It's a lot of resistance. You want to feel it, Dr. Patel? Go ahead and push through. Keep it going medial. You feel it? Go through? Yeah. Nice. So we'll go a little further, and we're in good position. Now we're inside the 045 disc. You can see there's a grade 1 listhesis, and we're not fixing that either. So for those of you watching that are interested, I had a question about this a couple of weeks ago. Somebody said, oh, if you have a spondylolisthesis, can you still do the laser surgery and fix my problem? The answer is 100% yes. That's because truth is spondylolisthesis 95% of the time is not the cause of your pain. It's usually the herniation that's the cause of the pain in the spondylolisthesis segment, if that's the segment that's the problem. So you don't need to fix the spondylolisthesis. It's a big misnomer. It's a big misunderstanding, misperception, whatever you want to call it. Everyone says spondylolisthesis, back pain, do a fusion. You don't need it. We can fix your pain without a fusion even when you have a spondylolisthesis. Now, if you have a grade 3 spondylolisthesis, it's a different story, right? Because your spine's about to fall off your pelvis, and we're not going to necessarily do a laser surgery for that. But point is, don't think just because you have bones slipping on each other or bones one on top of the other that you can't have laser surgery to fix it. You can. All right. So we're aiming a little high. Are you comfortable, sir? By the way, our patient's fully awake. Maybe some of you have heard of open brain surgery, right? Or awake brain surgery. Open surgery of the brain done with a patient awake. Shot. So we're not going to be doing brain surgery. Don't worry, sir. But the concept is the same. Why would you want to keep a patient awake during surgery? Well, the most common reason is that you need their feedback, right? They're participating in the surgery itself. And that's exactly what's happening here in my Deuk laser disc repairs. Did somebody yawn? Who yawned? Just kidding. She's like, oh my God. Do I need to start looking for another job? No, you don't. I'm just giving you a hard time. Just because it's kind of funny. You know, the boss is talking and teaching and somebody's yawning. It's like you see that in the movies. At least I think it's funny. Shot? So, yeah, there are surgeries done where the patients are awake. And there's two benefits to being awake. Number one, less anesthesia risk of the airway obstructing or something, or vomiting and aspirating, whatever. And then number two, they can help me, help them. Help me, help you, right? You've all heard that? Help me, help you. So the patient is helping me, help him. Did you know you were going to be part of this team here? He did. So he's been watching on TV or the internet. He knows the routine. He knows that I need his help. Shot? That's both good and bad, you know. You feel something there? Yeah. It's good for obvious reasons, but it's also bad because you know what's coming. The discogram. Shot? Right? Don't say what's a discogram. Yeah. There's only one way to know for sure, right, Dr. Patel? Shot. So I'm hitting the facet. I'm in line with the disc, so I'm happy with that, trajectory, but I'm too medial. So I need to back up and just go a little bit more lateral. I had to do that for the other level. Shot. Sometimes you just have to do that, Everybody's anatomy is a little bit different. Shot. Is that Lance again? Any questions from our audience? Who is it? Is that a chair for Carl? Oh, Carl. Are you going to have like a captain's chair that you set out on your boat? Is it comfortable? Yeah, AP. Is it like a wheelchair shaped chair? If you want, you can. Our gift to you, your retirement gift, can be a wheelchair that you can put on the captain's chair, right? And then when you want to go to shore, you can just like unclick it or unhinge it, and you can just wheelchair yourself. From Deuk Spine with love. Thanks for your years of service. All right. So that looks fine. We're now the needle at the top. So the other needle shows we're pretty shallow as well, but the spine is rotated. So go ahead and go back to a lateral. So the discogram part of the surgery has several uses in the surgery. One of them is it's how we gain access to the herniation through the foramen safely. Okay, so that's one of the most important reasons we do this this discogram procedure, the needle access procedure shot. The second is it actually stains the herniated disc nucleus a blue color so I can see it and you can see the annular tear better. Are you comfortable? Shot. So I'm just taking my sweet old time. Again, I can feel the herniation here. There's a lot of resistance to the tip, but not like bone, but like herniated disc. And again, I'm gonna head in, shot. So we're inside the disc, just like we are in the other one. Again, don't try this in your garage at home. This is not for beginners. So far we've made an incision on the left side, and the reason we did the incision over here is he has primarily left pain, and the herniations that I'm attacking are L34, L45 on the left side. Now, he also has right leg symptoms, so we're going to go to the right side as well. If a patient has only one-sided leg symptoms, I only treat one side. Do you feel that on your skin? Huh? Is it sharp? Not sharp. And that side is higher than the left side, so I think we're okay. And it's probably rotated slightly backwards as well. Huh? Everything okay? Good. You should stay here when you're done and learn how to do this surgery, and I can teach you. It would be great. All right, we need an AP. It's fine. So we're doing a Deuk laser disc repair, L45 bilateral and L34 left side on this patient. This patient's suffering with 25% back pain and sorry, did I say 25? No, 50% back pain and 50% leg symptoms of neurogenic claudication and intermittent sciatica. Shot. So our goal with this patient is to fix his back pain as well as his leg symptoms. Oh, is this scorpions? Can we turn the volume up, please? Yeah. Winds of change. Shot. Let's go lateral, please. Zach, any questions from our audience?
We do have one question. We have a viewer asking, is it true that exercise can help relieve symptoms from neck and back pain?
So somebody is asking, is it true that we need to get down the disc, so you're going to have to wag again, if you remember? Is it true, you're going to have to bring your base north and my side south, that exercise can help relieve symptoms of back and neck pain? Absolutely true. So if you are starting out with back or neck pain and you want to know what can be done to help my pain get better without having to have shots or surgery, the best things you can do are low impact aerobics, regular daily walking, I call it speed walking, which is where you're going to do a mile in 15 minutes, shot. And the way you do that is you actually get in your car and you drive from your house. Let's just say where you're going to start. Remember to let me know if it's uncomfortable, sir. You're going to start in your driveway and you're going to go half a mile with your car. Is that it? Yeah. You're going to go half a mile with your car and then mark that location, and then you walk to that spot every day, and you walk to that spot and then back home, and you time yourself and make sure you do it in 15 minutes. That's the 15-minute mile, and that's a really good way to do cardiovascular, but also to loosen up your joints and tone up your muscles in your lower back. The other thing you do is core exercises, where you build your core musculature. And I recommend doing it with a supervision, either a personal weight trainer or a physiotherapist. And then the other thing you can do is chiropractic, which is really good for your back. Medical massage, a lot of times is really good. And yoga is fantastic to prevent back and neck pain flare-ups. All right, that's looking really good. Carl, you all right? Shot? Let's go lateral, please. Great question. So we are big believers. You got to understand something. Back and neck pain is just a general term, okay? It's like saying I live in a house. If you want some more specifics, you need to be more specific with the details. So the same thing goes for back and neck pain. If you want to know the cause of back and neck pain, you actually have to. All right, so I'm hitting something bony. Shot? I think I'm hitting. Well, what the heck am I hitting then? Right? You see that? It's clear. It seems like the end plate. It's very interesting. Are we not seeing something? Let's get the table up slightly, please. I think it's the posterior superior, right? Patel? It's not the facet. Let's go with an AP. I think it's the posterior, it's the back of the vertebral body. You can kind of see there's a little nub in there. So I may have to come in a little bit higher, or I'll try to adjust to go higher at my entry point. But I think that's what we're dealing with. Yeah, there it is. Go back to a lateral, please. We're big believers in physiotherapy and muscle training, posture, gait training. And the reason is, if you think about what am I doing here with this surgery, I'm only fixing a joint. I'm basically fixing the disc. And Dr. Patel fixes a joint called the facet joint. Shot. So if you fix the disc joint and you fix the facet joint, which are the common causes of pain, shot, and the patient still has pain, then it's muscular. Shot. Thank you very much. All right. So we can't fix muscle pain with surgery. We can't fix joint pain. I mean, we can fix joint pain, but we can't fix muscle pain with surgery. Muscle pain is something that has to be fixed with therapy after surgery and before. Are you comfortable? Huh? All right. Are you happy? Are you hungry? He's hungry is what he said. All right. We got a salad for you afterwards, all right? Thirsty. All right, where do you feel that? How bad is that on a scale of 1 to 10 at its worst? All right. So he took Percocet, right, before surgery? Yeah. All right. Is that what? Is that where your typical back pain is? It is. So we have concordant pain. And you're saying the highest it got was a 3, or was it a little higher? 3 or 4. All right, so 4, we'll just put 4 out of 10 concordant. That was the L34 disc. Everybody agree? All right. So that's one of the discs that we're going to be fixing today. And that's kind of where you were pointing in clinic yesterday, where your pain's coming from, right? Because it was right above your old scar. You've had a microdiscectomy done elsewhere, and you were pointing right up at the top of that microdiscectomy scar, which was at L45. So yeah, it all makes sense. So I think we chose wisely by not choosing 5-1, but choosing 3-4. Are you more comfortable now? Was that a different kind of pain? On the right side? All right. And on a scale of 1 to 10, how high does it get? 4. Are you, you have some Norse blood in you? German. That explains your pain tolerance. Huh? Stubbornness. I'm German as well. I was born in Bremerhaven. Where were you born? Jacksonville, Florida? All right. Austria. All right, very good. Okay, so when you wake up, we're gonna be done with surgery. But right now, I need you to count from 1 to 100. Can you do that for me out loud? In German? All right, English. I'll settle for English. Oh, Spanish. All right. Keep counting, nice and loud. See, that's unique, right? A German born in Jacksonville, Florida, who speaks Spanish. Doesn't Jacksonville have a military base, a Navy base or something? Yeah, Navy base. Does he have any, I can't really discuss it, I guess, as it's identifying. I was going to ask if he has any military tats. Navy tats? All right. Gators? He has a gator tat? Nice. He's a Jaguar, a Jacksonville Jaguar guy with a gator. See, I knew I liked him. Of course, everyone knows that I'm a gator, that I trained at UF in Gainesville, shot. So you can see the guide wire is there at L45, and the reason why the x-ray got blurry is because the patient's breathing, which is good, but that creates what's called motion artifact, where he actually moves his spine while the x-ray is still taking a picture. So imagine taking a picture of somebody and they move during the picture, they get blurry. So that's why it went blurry. Alrighty then. Huh? Yeah. And pulsing makes it even more. So, you can actually see the herniation, right, Dr. Patel? It's the grade 5. I would call it a grade 5 tear. Yeah, now did you notice what he said? My right leg, right? So he was like mostly left, but also some right. Now we know that the L45 is indeed the cause of the right leg, which is why I did bilateral on this level. So if you want to advance it, you're welcome to. Just keep getting some shots as you do it, and look at that guide wire tip. All right, any questions from our audience? Nope. All right, so I'm going to point out as we do this, as Dr. Patel advances the dilator down, you can see right where the tip of that thing is in that x-ray is all this gray colored clouds. That's all arthritis. All right, so you're getting close to the herniation. You should be able to feel it pretty soon. And you check your guide wire move forward just a little bit, so pull it back a little bit, pull it back a little more. It's really unlikely for the guide wire to advance in the lumbar or cervical because it always hits a bone spur and gets lodged there. But you have to check anyway, because if it doesn't, you'll be up the brown creek without a paddle, as my mom would always say. Yeah, so you feel it, the disc, right? You feel the herniation now? Let me help you. So you've gone through the foramen and you're up against the herniation. It feels like a little rubbery, doesn't it? Like one of those, go ahead, like one of those little rubber balls, right? You know those little bouncy balls? Like you're pushing the tip against a bouncy ball. That's the herniation you're pushing against.
We have a question.
Yes.
We have a viewer asking, in your view, at what point does pain treatment move from management to surgery? Is it when pain tablets become regular, injections are required, or what?
All right, let's do one question at a time. because of my limited frontal lobe functioning.
In your view, at what point does
Lay
pain
still.
treatment move from management to surgery?
So when does pain treatment move from management to surgery? The answer is 2 months. If you're suffering with pain that lasts longer than 2 months, you should literally consider either an interventional procedure with a needle, like a rhizotomy for facet pain, or you should consider surgery. That's my opinion. That's the earliest. I mean, after 2 months, it's really an individual decision as to whether or not you want to really wait long enough, whether you can get time off of work to get the surgery done, whether you are medically fit for surgery, because we have to make sure that you're not going to have a heart attack or a stroke or anything while you're having your surgery, right? You want to be healthy when you wake up, just as you were when you went in. So to do that, we have to make sure you're medically fit. We have to check your EKG, chest x-ray, blood work, all that good stuff. So, and the second question?
They were just putting, they said, is it when pain tablets are a regular requirement, or is it when pain injections are required?
Yeah, so if you're having, here's when you need surgery. If you're having pain that interferes with your quality of life and it prevents you from doing what you want to do, whether it's hobbies, sports, work, family life, okay? You need to consider, and and the most important thing is your body can't fix it on its own, right? So when we give you pills for pain, those pills aren't fixing you. They're just making you feel comfortable while your body heals. You understand? So if your body is unable to heal the source of pain on its own, and that's usually give it 2 months to do so, then I think you need surgery to fix the problem. That's my opinion, because the longer you delay your surgery or your definitive treatment, the more deconditioned your body gets, the weaker your muscles get, the worse your posture gets, the more other joint problems you start to get, like knee pain, hip pain, right? The more work you miss, the more addicted to pain pills you get. So why wait? There's no point to wait. You don't want to wait. You only want to wait long enough to make sure surgery is necessary, because you failed to improve on your own. So you want a specific answer? I say 2 months. Are there cases where you go 3 months? Sure. There are times where you go 3 months. You know, it just depends on what problem you have and how you respond to the treatment. I don't know if I answered the question, but I hope I did. Shot? All right, I think we're in good position.
We have another question.
Sure.
We have a viewer asking, can chiropractic care help treat anything for spondylolisthesis?
Can chiropractic care help treat anything if I have spondylolisthesis? The answer is absolutely yes. The most common cause of back and neck pain is facet syndrome. Facets are little joints that run along your spine. They get arthritis and they get really bound up with scar tissue and inflammation. The best treatment in the world for that is chiropractic care and facet rhizotomy, which is what we do here at Deuk Spine Institute. And Dr. Patel, my partner here, is the best at doing that. All right, let's see what we got.
Amy, lights, please. Oh, you got it? Thank you.
Yeah, can you get one for Dr. Patel as well?
Sure.
So I just want to take a look. You always want to make sure you're in the disc and not in the aorta or iliac vein or anything else. If you see islets of Langerhans, then you're in trouble, right? What else? If you see the renal pelvis, you're in trouble. All right, so we're not in trouble, thank God. We're in the right spot. And you can see we're inside the disc. So Dr. Patel, come on over here and hold your camera, right? And go ahead and see if you can take the pituitary rongeur and get some of that herniation out of there. He wants to wrap your wrist first. So what we're seeing there at 12 o'clock is a torn annulus with some blue dye, which is the herniation. Close when you go in. And don't jab down, nice and slow. And turn it sideways a little bit, rotate it, yep, this way, so you can, no, there you go. Now you can see where you're grabbing. Go. Yep, you see the opening, grab and come on out and let Luis have some of that. Juicy disc herniation, yeah, just come straight out, don't bend it, don't bend it, don't bend it, let it come out naturally. You can't bend it, otherwise it gets stuck. You know, when you stick it in the hole, it has to be straight in and straight out, not, don't try to, right? You're gonna get, it's gonna get stuck in there. Nice. All right, get your laser in there. Say, hand that to Luis, get your laser fiber. So did I answer all the questions there, Zach, or do you have some more?
You go through them all.
We got them all? Good. Where's the pedal? Laser should be on 30. Don't hit the pedal with that. No, wait. You have to always see the tip down here. If you fire that thing inside the scope, you'll crack the lens and then it'll be $5,000. Is the laser on? Go ahead. Step on that pedal. Nice. And all you do is you roll it with your fingers. There you go. Now you're a laser spine surgeon, Dr. Patel. Dr. Patel has the same passion I do about being the best at what he does. It's the only reason I'm even willing to consider training him in the art. You got to pull it back and roll it with your fingers. Kind of twist it and it'll move the tip. See? Right? So we're using a laser. The laser tip has a glass tube that comes out from a protective coating, and it emits a beam of laser radiation. That's high energy radiation, very powerful. It's a form of electromagnetic radiation. It's not visible to the eye, the human eye, so we don't know, it's invisible basically. So when we see a little red dot or a little green dot, that's just a targeting beam. And the laser beam itself is invisible. It's not in the visible light spectrum. So it's electromagnetic radiation with much higher frequency. Don't stop. Okay? No, don't do that. See what happened to the covering? All right, let me just take over for a minute. So, thank you. So, can we use this fiber? Let me stand where you are. Can we use this fiber? You see, is it okay? Or should we clip it? All right. So you understand what I'm saying? You can't step on the laser and activate it while it's inside the endoscope. We got lucky. All right. So are we losing some of the beam out through the side, you think, or are we okay?
No, it's okay because you got a flat tip on there.
Yeah.
Now, if it was angled, the tip is angled, then you'd have actually a distortion of therapy.
Yeah, but that's only at the tip, not along the shaft, right?
Yeah, the energy shouldn't come out of the shaft. It comes out.
Right. So if the protective coating is compromised, will it come out of the shaft or not? Huh?
Actually, if that protective coating is not on there, it still won't come out the side.
It still won't come out the side, right?
Correct.
Do you know why? Anybody know why? No, you know why. I know why. I'm testing to see who else knows why. Anybody? Any, why will the laser beam continue to stay inside the glass tube and not come out the side? No. Doesn't travel in a straight line. No electromagnetic radiation travels in exactly a straight line. Why? Anybody remember their physics? Do you know? Do you know the answer? Yeah. No. It's not really true. So inside the glass tube is glass. You got to wipe that. I don't need this. And light or electromagnetic radiation hits the surface between the glass tube and the air or any other media, and there's something called an index of refraction where it causes the beam to shift its axis of direction of travel, and it shifts it whatever degrees it is. The engineers know this. I don't know the answer how much. It depends on the type of radiation and the media through which it passes. That's why things in water look distorted, like bent, because they're not really bent. They're just, there's an index of refraction where the light travels, it reaches a surface between the water and the air, and it bends it. It literally, like a pool ball hitting the side of a pool table, it changes the direction. So this laser beam actually bounces side to side through this glass fiber all the way till it comes out the end. And I just didn't know if this, yeah, it's bouncing. It's like going bing, 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 bing. Like, you know, when you're playing air hockey and you hit that puck, and it goes side to side, but it still goes straight. Anyway, that's a relic from my, huh? Well, it can't exit through the sidewall unless you compromise the sidewall. You get like a little chip or a crack. If you, say, bend it too much, you crack it, then it'll come out. Because now there's another surface, juxtaposed, where it will come out. Anyway, just interesting minutia. I've got to download. Since nobody's asking questions, I got to do something. All right. So you want to try again? You see what I'm doing here? So never, never, never step on it when it's inside your endoscope. Unless you don't mind spending money. And yeah, see how you're burying the tip down there? You don't want to do that. You don't want to bury the tip and then step on the laser because you have no idea what you're zapping down there. You always want to see the end of the laser fiber. Why are you not stepping on the pedal? It's inside the housing, yeah. Any other questions from our audience? Zach?
Not yet.
Be careful around that opening because if you crack it, no. If you crack it, it'll go through your finger. I've done that once before. You never do it again. I promise you. It feels like electric volts going into your body. It literally went to my bone. Yeah, you don't want to go down there. Just stay up there at top around 12 o'clock. Go from 9 to 3. Keep rolling it. And roll it. Keep rolling it. All right, good. Let me try. Huh? Let me try, Dr. Patel. Let me come back in. Oh, no, don't bend it here. You never want, see this here? You never want to bend it here. Yeah, what's your question? We have an internal question.
Oh, I was looking at the equipment, the coding.
Uh-huh.
Like the blue.
Yes.
What's the
What prevents the blue plastic around the glass fiber from breaking?
See like where it's kind of got the
Yeah.
little tail on it?
Yeah. So it's stuck together. I mean, plastic molecules are held together through covalent bonds, so it would be a covalent bond. I know that's not what you're asking, but that's the answer. What are you worried about?
Breaking off and getting into your surgical field.
Breaking off and getting into what?
Into your field.
Oh yeah, it's already in my field, right? So breaking off, if it breaks off, it's going to go up, out, just like all the fragments of disc do. Yeah. Yeah. All right. Any questions from the audience, Zach? Stand by. So this is all annular tear and some herniation. Good. Take it. Let me have it. All right. I'm going to pull back a little bit. There's some more tear there. Tried to heal. I need the laser on. Since there's no questions, turn the music up, please. So one thing you think about, Dr. Patel, as you do these surgeries is you want to think about your equipment. You want to preserve it. Stand by. Take.
We have a question.
Yeah.
We have a viewer who says, I got diagnosed with spondylolisthesis at age 19 1 year ago. How long without any PT until the condition becomes severe? Is there a time frames for which it progresses?
All right. So what I heard from our viewer was I was diagnosed with spondylolisthesis a year ago. How long till it becomes severe? Nobody in the world will ever be able to tell you that. It's impossible to know. It could be never. It could be next year. Most likely it'll be probably 5 to 10 years. And the next question was, what was it?
It was, is there a time frame in which it progresses?
Is there a time frame over which it progresses? The answer is usually it progresses over years rather than days or weeks or months. It's usually years. So what kind of symptoms might you expect to get when it becomes symptomatic? Number one, you can get back pain. Number two, you can get leg pain, leg weakness, leg numbness, and leg tingling. Okay? So any of those are possible.
We have another question.
Yeah, if it gets really bad, you can actually start losing control of your bladder and bowel. Yes.
We have a viewer asking, when is Carl leaving on his trip?
When is Carl leaving on his trip? I can answer that. Not soon enough. I'm joking, of course. Gosh, tough crowd today. Stand by. Grab her. Carl is leaving. Carl, when are you leaving on your trip? This is a tough crowd, man. They want answers. And I don't blame them. They're probably asking all the right questions I should ask you too. When are you leaving on your trip, Carl? Huh? A little while. Carl is being vague. Very vague. Vague, vague, vague. Who's asking that?
It was Derek.
Derek. Hello, Derek. We'd like to know too. Inquiring minds would like to know. We really don't know what Carl's up to be quite honest with you. I think he might be like a CIA agent or FBI agent or something like that. You know, one of those people that you find out later on they work for the CIA or the FBI and you're like, I would never know. He was so quiet. He was so pleasant. He was so diligent. But no, seriously, we don't know when he's leaving. It's probably going to be in the next month or two. At least that's what he tells me. So I think some of these people, Carl, really want to go with you. Are you taking anybody with you, Carl? Besides your immediate family and your dog? No, sorry. The boat is full. All right, the last part of the tear, and then you see the epidural space. Is there another question? Look at how the laser coagulated that vein.
We have a viewer asking, what caused that blue plastic to get?
What caused the plastic to tear?
Yeah.
Well, that's a great question. They do tear. They do fray. I think what happened was we fired the laser when it was up against the metal, and that caused the discharge to immediately spread to the surrounding area, and it caused the plastic to melt off. Yeah, people don't understand just how powerful a laser is, but they can melt metal. Look at all the blast marks right there. That's metal, stainless steel. Not just any stainless steel, folks. This is German stainless steel. German is the best stainless steel you can make. There probably was a time when the best could be made in the United States, but those days are long gone. Our steel mills are all but closed. I'd like to see them reopen again. I'm hoping Donald Trump is able to at least do that, get the steel mills fixed. We got to stop relying on importation of steel and make it ourselves, but still protect the environment. My opinion. But good German steel, yep, that's blast marks made in good German stainless steel. So that shows you just how powerful this laser really is. And we don't even have it turned all the way up, by the way, folks. I could turn it up. I mean, really turn it up. But I've been using this setting right here at 30 joules for 13 years. So I've tried different settings that deliver more energy, and sometimes you might need to, but it's extremely rare. Like if you're going through a bone spur. But generally the 30 watts, right? The settings we use are enough. I think this laser goes up to 80, if I'm not mistaken. Does this go up to 80 or 100? 100. Oh, 100. So we use 30 out of 100. So there's a lot more power there if we need it.
We have a question. We have a viewer asking, how long will it be before the patient is allowed to return home?
How long will it be before what?
The patient is allowed to return home.
Oh, this patient's going to go home in an hour and a half from now. We're going to be done with this surgery in 30 minutes, and we're going to send this patient home basically an hour later. Our first patient that we did, the cervical, is ready to go home. I'm just keeping her here, stand by, because I want to see if we can do a quick video of her before she leaves. They live in Miami, and I don't know if they're staying locally tonight or not, but Miami is about 3 hours away, so I want to see her and hopefully get to introduce you all to her before she leaves. Again, she was a cervical laser from this earlier today that we did before this case. All right, we're just about done on this left side at L45. Remember, there's a spondylolisthesis here, which we're not fusing. All we're doing is fixing the herniation associated with the spondylolisthesis. I believe this is going to fix the patient's back pain, and I think it's going to fix the patient's leg pain. So this particular patient's had surgery in the past. He went for a microdiscectomy. Microdiscectomy is pretty much what every other surgeon in the world does for a herniated disc. But the problem with microdiscectomies is it causes the spine to become unstable. You don't believe me? Just look at this patient. He has a spondylolisthesis as a result of his microdiscectomy. So he went and had bone removed from the back of the spine, which is what every surgeon does in a microdiscectomy, that bone removal process made the spine weak, and now it's slipping. His bones are slipping. And doctors don't tell you about that. Why? Because if they tell you about it, you're not going to have the damn surgery done. That's why. So Dr. Camden figured out, well, why should we weaken the spine? Let's go through a natural opening in the back of the spine there, off to the side. And he developed the transforaminal approach in Philadelphia. So that was years ago. And then Dr. Young took it and modified it and made it better and taught it to me. And then I took it and modified it and made it better. And that's the Deuk laser disc repair. So really it's a third generation surgery that has been modified by me to make it better than my predecessors. And this patient has a spondylolisthesis, but I'm not fusing it, even though I could, because he doesn't want it fused. He just wants the pain to go away, and I can do that without fusing it. All right, we're done here at this level. You may. I need to suck the juice up. Let go. Let go. Huh?
You inject this side when the we're gonna go other side. Still you inject it.
Yeah.
It's bilateral.
Yeah. Yeah. I mean, most of the story comes out. Look at that. See that? Very little stays in. About 80% of it just comes out because it's a giant tube and it just pulls it out. There's like a suction, you know?
Right.
But if a little bit gets in there, that's great. That's what I want. Okay, guide wire. Take. So now we're going to move to 3-4. Thank you, Dr. Patel. I got it for just the right now. Keep going. You're doing great. Tell me when you're ready to take a shot. Shot? Great. I bring the table up a smidgen. Luis has got pressure. So about it, I just hold this, rest my hand here. This is all sterile still, right, Carl? Shot. So I think we should be up at 3-4, which I believe we are. Any way we can change the music, shot? We need something soothing. Shot. All right, there we go. So guide wire is in position. I can take out the spinal needle. Shot. Want to make sure I'm not pulling back the guide wire or advancing it inadvertently. Shot. Felt it move forward. Okay, we're still okay. Looks like a tear anteriorly, right? Yeah, there's a tear anteriorly. Shot. You see it there at 3-4? Right in front of the guide wire tip? What other questions do we have there, Zach? Anybody from the audience? Okay, you gotta be able to take what I'm giving you and give me the next instrument. There you go, good. Okay. I don't conform to your needs, you conform to my needs. You understand the difference?
We have a viewer asking, can the Deuk laser disc repair also be used to remove osteophytes?
Osteophyte. Shot. Can you bring this away from the table so I can try to work here a little bit? Could this be used to remove osteophytes? The answer is yes. We do remove osteophytes. And shot. The Deuk laser disc repair endoscopic surgery can be used to remove small symptomatic osteophytes, not gigantic osteophytes. So there's small, medium, and large. I would say we could remove all the smalls and half the mediums and none of the larges. Shot. So I would need to take it on a case-by-case basis and see how big the osteophytes are and where they're located. Shot. So I'm up against the disc once again. Dr. Patel, you want to do the honors? No, hold on. You're up against the disc. Just take this. Okay, now the way you do it is you go down. Yep. Now you're going to have to offset it. There you go. And you have to keep it offset while you do it. So I'll let you play with it a little bit. Hold on, let me see. You want to see the interface. Let me see. Okay, good. Yep. So, and you want to angle this way slightly. Yep. Because if you go that way, you might end up in the fecal sac. Nice. Now your guide wire is advancing too, so just be cognizant of that. It's probably because it's getting pinched somewhere. All right. Shot. All right, that's good. Keep going. You're doing great. Uh-huh. So you're a hammer wielder now, are you? Huh? A mallet wielder. Good for you. You're no longer just a needle jockey, Dr. Patel. Good. You understand what I'm saying to you? You're evolving. Let go. You're developing surgical skills. Well, hold on now. I want to see all this myself. Shot. That looks pretty good. Yeah, go ahead. So this, wait, before you do that, just real quick, folks, take a look. I guess we're already there, so go ahead. We're putting our tubular retractor in, and I wanted you to compare it to the last surgery for the neck, where we fixed the discs. And remember, the one for the neck was very skinny, and this one is about twice as wide. So for cervical disc herniations, I use a 4mm wide tubular retractor. You're done. You got to bring the other thing down. You won't get any further with your hand. It's too hard. So go ahead and put that in. So with cervical, we use a 4mm wide tubular retractor. For lumbar, we use 7.2, I think it is. Good. Keep going. Keep going. Nice. You're done. Take your dilator out, but do not take the outer tube out. So hold the outer tube and twist it out. There you go. Shot. Nice job, Dr. Patel. You are the man. You have one layer of gloves or two? Good. All right, you know where that goes? I can't teach you all my tricks, Dr. Patel. Not all of them just yet. See? I teach you that one. All right, get your scope in there. Let's turn the scope on and see what's down the rabbit hole. Remember, don't bend it. It's got to go straight in nice. If you bend it, you'll break it. These are not meant to be bent one bit at all. No more than at 1 degree. Turn your irrigation on. Go down. There you go. You're in the disc. See that? Great job. You did it. All right. Grab some of that out with your grabber. Pituitary. Remember, do not bend it. Let it go where it wants to go. Now pull back a little bit and look and watch it enter your field of view. Turn it and go grab. Everything okay, Coral? Understood. All right, let Luis have that and get your laser fiber in there. So what we're looking at is the herniation inside, from inside the disc. And this is the safest way to remove a herniation is from the inside out technique. Fire away. Rock and roll. All right, I'm going to go have a cappuccino in the other room, and I'll be back shortly. Everyone knows I'm joking, right? Luis, except for Luis. He's like, get me one too. Don't go down a hole. All right. Mind if I take over for a little bit? You're doing really good, but I want to move things along. Great job. How was it? Was it good for you? So you're learning step by step all the little pieces. Someday you can put them all together. Right, Dr. Patel? What do you think about that cervical case? Yeah. So this is scar tissue here. What do you think about cervical Deuk laser disc repair versus ACDF? Why do you say that? Just because I'm standing next to you.
Much better.
Yeah, I mean, you've seen scar, less complication, less scarring, physiological movement. Whoa, my toe is getting wet.
Hey, can we have a towel, please?
It's so funny, this bag design changes every single surgery. When are we going to figure out the right way, the right conformation? Any of the viewers and listeners, if you've got a sterile bag that will keep me from my toes getting wet during these surgeries, I'd be very happy if you share your design with us. You're going to put my feet in garbage bags?
We have a question.
Yes, question.
We have a viewer who's asking, how large are the herniations that are being removed with the laser?
So Zach, your voice is trailing off.
They asked, how large are the herniations that are being removed with the laser?
How large are the herniations being removed with the laser? They are medium-sized herniations. And if I had to give you a size, I'd say 5 millimeters, 5 to 7 millimeters. They're not that big, but they're in just the right spot. They're in the back of the disc to the side where the nerve is. So they're, every time this patient stands up and walks or stays standing for a while, he gets pain and weakness and numbness down his legs. And he has difficulty walking for a while, standing for a while. Here's a herniation right here. Here's part of it just stuck back out, laser off. So, Dr. Patel, have you been to the Phillips Center for Performing Arts yet?
No. I saw from the outside.
Yeah. I haven't been in either. I would love to go. I'm trying to find a show to take my family. I don't know. So these herniations are really not humongous, but I think that most radiologists would make the right diagnosis when they look at the MRI. Oh boy. That's another issue in spine care and healthcare is radiologists not reading the MRIs for backs and necks properly. Happens all the time. They underread them. They call them normal when they're not. And if you are looking for something that's abnormal, but your threshold for calling it abnormal is so high that everything you look at looks normal, then you're going to miss a lot of problems that are causing symptoms that are not normal, but you're not calling them abnormal because you have a very high threshold. That happens quite often. Insurance companies love it. but patients suffer as a result of it. And after all, why do we practice medicine? Why do we get tests done? We want accurate information so that we can make the right diagnosis and prescribe the right treatment and perform the right treatment. So often what's good for patients is not good for an insurance company and vice versa. Yes, Zach.
I'm sorry, sir.
Did you have something to add, Zach?
I did not.
It's pretty, huh? It looks like a glacier. A glacier inside the disc. By the way, this is all completely abnormal. It's just the way the tissue is responding to the laser indicates there's a lot of collagen, a lot of scar tissue in it. That's the tear, by the way. Listen, if you're out there watching this live on April 25th, 2019, and right now it's about 1:30 East Coast time, feel free to ask questions. And the reason I say that is your questions don't distract me one bit. And if they do, I'll just stop what I'm doing or I won't answer your question. Laser off. And I won't, don't worry, you're not jeopardizing the safety of this patient by asking me a question. Okay? The whole purpose of having you here is for you to interact and learn while we're doing it, which means you need to ask questions so you understand what's being done. These are all pieces of herniated disc. They're stuck down to the annulus. They're scarred down from inflammation. They don't come out when you put that pituitary in there. You really have to get in with a laser and get them. That's why laser is necessary. Like I was telling people a week ago when I did a surgery, I was talking about my training and the laser and everything, and all the attendings in my program at UF in Gainesville would laugh at the use of lasers in spine surgery. Of course, they taught the residents to laugh about it as well. So when I left my training, Laser Spine Institute was considered a joke. But the truth is that, yeah, they still were a joke, to be honest with you, because they never did this approach. They actually did a microdiscectomy approach, so they had to remove bone. And they really didn't use the laser either. But the whole idea and concept of using a laser to repair a disc was basically laughed at. And it still is to this day by many orthopedic and neurosurgeons, because they really don't understand the value of this tool, right? It's kind of like somebody back in the day laughing at Orville and Wilbur Wright as they jumped on this contraption and started gliding through the air. And they are laughing at them like, what's that? Who could possibly need that stupid toy, right? And now, of course, it led to the advent of modern aviation. There's a reverse herniation. The point I'm trying to make is, just because ideas aren't popular and not understood by the general public doesn't mean they're bad ideas. It just means that they don't understand the value. So I honestly did not understand the value of this tool, the laser, when I was in my neurosurgery training for 7 years. We used the laser occasionally in training to do some pediatric cases. Dr. David Pincus was the first one to introduce me to the laser. He's a pediatric neurosurgeon, and I have to admit I was impressed with the performance of the laser as a resident. And again, that was dealing with kids' spines, because their spines are smaller. So, well, guess what? This view right here, the endoscopic view, is a smaller view. So that explains probably why a laser is so valuable as a tool, is because we're working in a very small space. And when you work in small spaces, the laser becomes a very valuable tool. When you work in big spaces, you don't need a laser, right? But when you're doing endoscopic surgery or microsurgery, laser becomes a valuable tool. So I think this whole notion that lasers aren't needed in spine surgery is just, you hear it from people who don't do this type of surgery because they don't understand the value of a laser. And they never will, because they're, frankly, they're never going to.
We have a question.
Yes.
We have a reviewer asking, does this type of laser surgery apply to
Zach,
all type?
You really do have to raise your voice. We got a lot of noise with the lasers fan.
We have a viewer asking, does this type of laser surgery apply to all disc herniations, like
We need
protrusion?
laser on, my friend. Hello? Does this type of laser surgery apply to all disc herniations?
Like protrusions, extrusions, and
Sequestrations? Yes. This surgery that you're watching can be used for all types of disc herniations. And by the way, thank you for asking the question, because it's a really good question. It really highlights the fact that there are so many different names for different kinds of herniations, but they all mean the same thing. They're all herniations. The answer is yes. The laser can be used for any type of herniation, whether it's a protrusion, extrusion, sequestration, extrusion, doesn't matter. As a matter of fact, this is a much better tool to use than standard neurosurgical tools. You can see how effective it is at removing tissue that's pathological. Look at that tear right there. Beautiful. There's a herniation right there. The blue thing. Looks like blue ice. All right, so I'm about 5 minutes away from finishing this disc, and then we're going to go to the other side and do the L45 on the other side. Remember, we're at L34 right now. We're at the disc above. The reason I knew this was a problematic disc for this patient is highlights the importance of the physical exam. The patient came in and basically I said, "Where's your worst back pain?" And he stuck his finger. Luis, you got to get the tissue out of here. Okay, so when you have this, okay, you have to get the stuff out while I'm doing other things. You understand? It's not a hard grab, it's a strategically placed grab. Do you understand? So what you're dealing with is a situation where there's tissue embedded inside a cup. So rather than grabbing the outside of the cup hard, see? Technique. It's all about technique. It's not about how much force you use, it's about how you apply the force. So you have to stick your Raytech inside the cup and pull it out that way. Sorry, I was in the middle of explaining. Why is the fluoro moving? Why is this moving? Why is the arc moving? It should be locked down, guys. When you walk away from a fluoro, you should lock the arc. Okay? I was in the middle of explaining the effectiveness of the laser on extrusion, protrusion, sequestration, and extrusion, protrusion. Was that what I was talking about, Zach?
Yes, sir.
I think I might have answered it. So, was there another question?
We do. We have a viewer asking, do you think that the attitude some people have against the laser is because clinicians feel threatened by the new technology and the fact that it reduces patients' reliance on long inpatient stays / income?
Yeah, great question. So somebody is saying, hey, do you think the reason why some individuals like surgeons or hospitals or entities feel threatened by the laser is because it basically provides an advantage to the patient that surgeon or facility is not capable of providing the patient with more traditional surgery? And the answer is absolutely yes. That's why. The laser surgery that I'm performing right now is by no means equal to any other surgery done. Fusion, artificial disc, microdiscectomy, laminectomy, foraminotomy. It is far superior. And the reason it's superior is because of its results. The results are better with respect to pain relief. The results are better with respect to complication. The results are better with respect to length of stay and location where it's done, site of service. The results are better with the cost. The results are better with everything. So yeah, it's kind of like somebody showing up, to a game. Like imagine playing a basketball game in the park and then Magic Johnson shows up and he's going to be on one of the teams. Well, everyone's going to fight like heck for him to be on their team, right? And so yeah, I think that people are intimidated by the technology because they don't know how to do it. They don't know how to use it. They don't have access to it. They don't have the equipment. The hospital won't buy it. It's too expensive. Whatever the reason is. So yeah, they feel very much intimidated by it. Just like a professional athlete showing up at a pickup game, people are going to be intimidated because that's a pro athlete. They know that person's better trained, better prepared, more experience, et cetera, at fixing a problem. The problem is losing. You don't want to lose. So your pro athlete is going to prevent you from losing, which means the other team's going to lose. So, in medicine, surgeons and hospitals, we compete for patients, to fix them. Every surgeon thinks that he's the best at fixing, or he or she is the best at fixing a patient. And I'm not trying to be sexist. I mean he or she, whether it's a male or female surgeon. And the fact is that, each of us have certain things that we do. Yeah, go ahead. We do really well. Like, for example, I'm really good at figuring out why people have pain, and I'm really good at technically at fixing it. But I'm not so good at sitting down and having long-winded conversations with patients. So every surgeon has attributes that are really special, and they shouldn't feel less because they don't. But what we should do is focus on what we're good at and capitalize on those strengths in our qualities and our personality and our ability, basically, and not try to do things we shouldn't be doing. That's why I don't do aneurysm surgery. I don't do AVM surgery. Can I do it? Yes. Am I legally allowed to do it? Yes. Am I trained to do it? Yes. Am I a really good surgeon able to do it? Yes. Do I do it? No. Why? Because I leave it for the other doctors that are better at it than me, that are better prepared, that are better trained, that are more experienced. It's just that simple. And if the same thing happened in spine surgery, if the surgeons and hospitals would just recognize that there should be centers of excellence where you can go to have specific types of procedures done, that would be great. For example, somebody asked me earlier in the last surgery, do I do Chiari-1 malformation surgery? And the answer is yes, I can, but there are actually centers of excellence for Chiari surgery, where people literally travel from around the world to go and get Chiari surgery and treatment done. Why? Because those doctors there love treating that problem, and they're passionate about it, and they're really good at it, and they know everything there is to know about which drugs are better, which surgical techniques are better, which ones have a higher complication rate, what are the complications, how do we deal with the complications. So what I'm getting at is that in medicine, we need centers of excellence where people go for specific types of treatment. And Deuk Spine Institute is really a center of excellence for advanced spinal surgery and advanced spinal care, and not so much aneurysms or AVMs or tumors or pediatrics or shunts or hydrocephalus. We're really good at really one thing, and that's herniated discs and pain. So if we all just accept the fact that we can't do everything and can't be everything as doctors or as people, then we can focus on what we're really good at doing and be the best at that. I guess what I'm trying to say is, yeah, they may be intimidated by the laser technology because they don't know how to do it, but that's okay. Don't be intimidated, just accept that you're better at other things than we are and move on. But send the patients to where they should be. That's your first responsibility as a doctor. Always send the patients to the best that you can get them. We are almost done with this disc. It's taken a little longer than I thought because there's so much little scarring but it's not dried out completely, so there's a lot of work that's done, even with the scarring. You can see the posterior longitudinal ligament up there, those fibers at 11 o'clock, right in there. We're not going to mess with those guys. We don't need to. They're not part of the problem. Just this herniation here that is. And I'm doing the annular debridement. So far, we've had some really good questions from the audience. I appreciate the questions. They certainly make my day more interesting. I know they make Luis's day more interesting as well. And I have Dr. Patel here, by the way, standing next to me. Dr. Patel is my partner. Not my, like, partner, but my professional partner. I have to be careful how I say that. But Dr. Patel's been with Deuk Spine how many years now? 10 years? 12? Oh God, I'm so sorry. 12 years. I still remember you getting your gift for 10 years. And I thought that was like a few months ago, but that was 2 years ago. 12 years at Deuk Spine. Dr. Patel is as much Deuk Spine as I am. And literally, in my opinion, I've said this to many people, he's the best interventional doctor in the world. And a lot of that is because the guy actually really cares, just like I do. He wants his patients to have the best. He wants to do the best. And doctors that care about their patients are going to give their patients their absolute best. Dr. Santiago is the same way. That's why I'm trying to recruit him. So, stand by. Deuk Spine Institute, he's moving just a little bit. We're not quite ready yet. So, yeah, probably because we're in the most painful part of the disc, obviously. The outside, the outer annulus. I'm just about done, and then we'll just wait. That's all looking good. Let me know when I can proceed. Hold him, Luis. He's strapped down good, right?
Yes.
Yeah, it's always important to strap people down. You never know when they're going to buck. Can I start or wait? So, point I'm trying to make is people out there wanting medical care, the best medical care possible, you've got to find doctors that are absolutely passionate about what they do. I know it's hard to believe there are doctors that are passionate about what they do, but there are. I promise you. There are not many of them, but there are doctors that are passionate about patient care and being the best at what they do. It's kind of a badge of honor, I think, for us. We want to go home at night and go home every day and say, you know, we did an amazing job today at work. It's a way of validating ourselves for what we do, you know. Unfortunately, these days, patients don't show their appreciation to doctors like they used to. My dad was an OB-GYN. I told you he was a doctor in the military, United States Army. And when he practiced, he would literally come home every single day with cookies, cake, gifts from patients, thanking him for what he did for them. Those days are gone, and that's okay. It doesn't bother me that they are, but the fact of the matter is doctors, a lot of us went into medicine because we want appreciation for what we do. Not in terms of like we always want to be patted on the back, but we want to do a good job and we want to be appreciated for doing a good job, if that makes sense. I think that's a good quality in a person. So if you have a doctor that tries their best for you, show some appreciation to them. It really matters. It goes a long way. I have patients that bring me nice letters and they write poems. I've even had a patient who wrote a song about Deuk Spine and the care they got because he was a guitar instructor, he was a musician, and he wrote a ballad. And we have that on one of my exam room walls. And he talks about how he cured his back pain and made a huge difference in his life. You know? So that's what's important to Dr. Patel, Dr. Santiago. As a matter of fact, everybody in this room, I can tell you, I know every person here, and every person here is motivated by the same thing, and that is to help people get better and out of illness. At Deuk Spine, that's how our people are. We won't hire people, we won't keep people that aren't. So, it's our culture here. And honestly, it should be that way at every doctor's office. All right, just about done. You can see we've debrided this tear all the way to the PLL. So there's no more herniation left. The PLL is at 12 o'clock. That's the white thing up there. And I've gotten rid of the herniation, the interposed disc material. That's the blue stuff. I feel really good about it. You can see this whole thing needs to heal. Now this may look like a lot to you, right? I get people say, oh my gosh, how much of the disc did you take out? I didn't take any of the normal disc out, first of all. All I've taken out was the herniation. And if you want to know how big this is, okay, the blue tube is 1/2 millimeter. So really from side to side, you're looking at about 6 millimeters, right? That's how wide this is. And so we really haven't removed much of the disc at all. And we certainly haven't taken any of the normal disc out. This is all herniated disc. Okay.
We have a question.
Yes.
We have a viewer asking if someone wanted to learn this surgery, how long would it take to be trained and ready to perform it?
So if someone wanted to learn this surgery, how long would it take to be trained and perform it independently? I think it depends on the surgeon that I'm dealing with. And it has to be a surgeon, by the way. I would say a minimum of 20 cases, 25 cases, up to 50 or even 100 cases. So it just depends on the person I'm training, their skill set, their comfort set, their knowledge of the anatomy, their just how qualified and how competent they are to begin with. Laser off. And then how quick of a learner are they? I mean, are they stubborn and pig-headed? Am I going to fight them on everything? Or are they going to be open-minded and willing to learn? Those are all important attributes. There's the nerve right there, the reddish thing, and a little bit of fat. There's where the herniation was, just under the nerve. And we are done with this disc. And I'm going to come out. There's the epidural fat there. I'm going to suck all the juice out. And then we'll move on to the last disc. Scope off. All right, I got it. I'll let you come in a minute. All right, so we're coming out with a tubular retractor. And next, we don't want to drop that scope. Next, Luis is going to apply, or Dr. Patel will apply some pressure to the paraspinous muscle. I'm going to go to the other side. Whoop, whoop. All right, one more disc to go. I should say one more side of a disc.
We have another question.
Luis, part the Red Sea. Yes. I need the pedal for the laser. Question.
We have a viewer asking, is MRSA a risk in the USA, and do you screen patients for it prior to surgery?
All right, so great question from one of our viewers. The question was, is MRSA, or MRSA, aka methicillin-resistant Staphylococcus aureus, a risk in the United States? And do you screen patients? And how do you deal with it? Yeah, that's perfect. Thank you. So to answer your question, MRSA is definitely a risk anywhere you go in the world. And Staphylococcus aureus bacteria live on our skin. They colonize our airway. Normally, they colonize our gastrointestinal tract. But methicillin resistant, are we good there? That's it? Methicillin resistant Staphylococcus aureus is potentially it is an opportunistic pathogen, meaning it waits for the right opportunity, but it is not pathogenic by itself. So it needs to be presented with an opportunity, right? In other words, there has to be a surgical wound, and the bacteria will get in through that opening, like a skin opening, or it'll get on some metal and start to colonize it and then cause an infection. So in other words, it can't just go through your mucosa or your skin and cause an infection, or your gut. It has to have a pathway. Something has to create an opportunity. Therefore, opportunistic, right? So MRSA is an opportunistic bacteria. We do have it in the United States. It can be a problem, though. What do we do to mitigate against that risk? We use vancomycin, okay? And vancomycin is a very inexpensive antibiotic, easily available. And we use vancomycin powder actually on all of our open surgeries. And we're not doing really an open surgery here. We are, but we aren't. We don't put vancomycin into this tiny little hole. But when I do my ACDFs or my lumbar fusions, anytime we do a big incision that's bigger than a centimeter, we put vancomycin powder. And that's deep inside the wound. It's called topical vanc. And it's been shown to reduce the risk of MRSA infections dramatically. Huh? Yeah, right, we do chlorhexidine scrub. We monitor people's, diabetic status to make sure they're not immunocompromised. We do about 100 things to prevent infections. But they start with, in the office before surgery, and then in the pre-op area, and the recovery area, and the operating room. There's lots of things we do. And as a result of these strategies, as a result of the strategies we use, we've been very fortunate that we haven't had any infections, and now we have not had an infection in about 8 years with spine surgery as a result. I'm talking about all surgeries, whether they're fusions or they're endoscopic. Now, we've never had an endoscopic surgery with an infection, never. Not in 13 years and 900 cases. But I have had infections in the past in fusions. And ever since we've used the vancomycin powder, we haven't had a problem. Let me just check this. I think we're okay. Take it. Yeah, you see what's pinching it? What? Are you talking to me? Oh yeah, we do antibiotic irrigation. We do a lot of stuff. So I don't want to give all of our secrets away. The board might kick me out, right? No, but seriously, we do too much to talk about right here, right now. But we do a lot to prevent infections, including irrigation, IV antibiotics, topical, a lot of topical stuff. So, metabolic stuff, controlling sugars, making sure patients are healthy and fit, they have good immune systems, et cetera, et cetera. So, temperature regulation, bleeding regulation, all those things. Shot, that's where we are. Good question, very fair question. I like questions about infection. Shot? Mostly because we don't have any. So it helps us stand out from our competition. Shot? All right, that time the dilator advanced. So let me have the dilator grabber. Whew. Is our first patient ready to go home?
Yes, we're ready to go.
All right. So let them know that I'll be out in 10 minutes. We're going to ask if we can do a video. Would you have the nurse ask if we can do a video? If the patient's okay with it. Shot? Yeah. Before they leave to Miami? Miami? Anybody know what Miami stands for? Miami. My friend, right? Mi amigo. place I like. All right. Me. Any more questions? I love questions. This is the right side now, right L45. Again, we're in the disc. You can see the disc there. And remember, we were on the other side of this disc, so we took out about 5% of this very disc on the other side, right? And now we're taking out probably another 3 to 4 or 5% on the right side. So I don't expect this to take as long. I mean, look at that beautiful tear. Dr. Patel, you want to come on over? You still have your wrist guard? So pull back just a little. Right about there. It's perfect. And go clean that annular tear up. The pedal it should be at your right foot or your left foot. Bring your left foot out. South. Yep. Careful now. Come out. Come back. There you go. So any more questions for me? Keep going down, down, down. There you go. Clean it up. Yeah, nice.
Not yet.
All right. You got to roll it in your fingers. Look at me. Like this. And turn your hand. And learn where it moves when you do that. Keep going. Is there something going on with the irrigation? Or are we good? Keep going. Hit that pedal. It won't do anything unless you hit the pedal. You got to move. Move it around. Otherwise, you can't just stay in one spot like that. It won't do anything. Let me see what you got going on. There's bleeding. It's coming from the disc. Probably from the other side. Don't go in that hole. You got to stay on the surface. Yes, there. Roll it around there.
She said yes, she is willing.
Ready to go? Oh, she's willing to do the video? Will you, Zach? Either you or Sonny, one of you guys head over to recovery right now? We're going to do a live stream of the first patient. She was going to go home and we'll do a video. You got to get that chunk.
I'll get it ready.
Don't go in that hole. Do you understand your target? Right there. There you go. Move your scope. There you go. Now you understand? It takes experience and practice, I get it. But I have to tell you the right thing to do, otherwise you'll never get there. Come closer so you can see what you're doing. There you go. Don't go down the hole. Yeah. All right, go grab that chunk of disc herniation there on the right. Take your laser out. Laser on standby. Pull your scope back a little bit. It's kind of a fun surgery, isn't it, Dr. Patel? To me, it's a miracle surgery. Turn. Because, I mean, just to be able to do surgery like this with such a small incision and a fast recovery and minimal to no blood loss and so successful, I mean, in terms of outcomes, is incredible. Under MAC, no anesthesia, no intubation. I mean, it's versus an open, painful, bleeding, scar tissue, complicated. It's so elegant. Oh, that's a big hunk of herniation. Grab it. Come on, Bada. Show it who the boss is. You're going to have to pull back. I don't know if you got it. Did you get it? I think it may still be in there. There it is. Go and grab it. Look how smooth that is. That was on the end plate. Get him. Turn. There you go. All right, I'll give you a couple more minutes and I gotta come in. There you go. Now look, you keep doing the same thing. You keep hitting the end of your scope and it breaks off. So you got to take the whole thing out, scope and retractor. That's why you see me do that sometimes, right? You see me come out with a scope and the pituitary out of the retractor completely. And that's because they're too big. Some of these pieces are too big to fit. Out. Now come out. Oh. Good. Turn the other way. There you go. Grab it. All right, try again. It's all right. Just takes experience and practice. Now come out. Yep. Try not to hit the end of the scope before you come out. There you go. Keep going. All right. We're almost there. A little bit further. Go back in. See it? Yeah, just get them. There you go. You're out. It's still on the end of your scope. Lift your scope out. Just lift it out. There, should have floated out. All right, let me take over for a little bit. Good job.
It's sitting there.
I'll get it. Don't worry.
Right here.
I see it. Watch. Go away. Go away. Whoa. Whose idea was this? This is horrible. All right, you guys get to buy Dr. Patel and I new shoes. Guys, you got to understand, if you have a bag of water, okay, and you have fixation points that are equal, where do you think the water is going to go? To the middle. No, to the middle.
Yeah, but the suction are
It's kinking. So you have to direct the fluid in such a way that the hole that it goes out is at the lowest point. Like this, not like this. Like this. Okay? You're going to have to change this next time so it's going like that. The egress hole has to be at the bottom of the pyramid, bottom of the angle. It's all right. I'll get it. Let me have the grabber, please. So I've been doing this surgery for 13 years, and of all my assistants, no one has figured out the way to keep my feet from getting wet. I think one time we had it figured out, right? Didn't we? Where's Carl? Nope, that's not the solution. Who said ortho boots? Who said that? All right. So let's pretend I get ortho boots and water continues to pool on the floor through the case. And suddenly you feel a little bit of electrical current shooting up your leg. What was the problem with your solution? You thought about me staying dry, but you didn't think about the rest of the people not being electrocuted, right? So the fact of the matter is we need a collection system that works, and this works, but it's literally has to be set up properly. And I am not going to do it. I refuse. This is one problem that I'm not going to solve. So I'm just going to start getting super nasty with you guys when you don't solve it. So Luis, I'm going to find a way to make you suffer. Okay? Unless you solve the problem. Because right now I'm the one whose shoes are getting wet. And there's one thing in life that I absolutely have zero tolerance for. Do you know what it is? Okay, so I will accept somebody lying to me. I will accept somebody stealing from me. I will accept somebody kicking me and punching me and beating me up physically. But I will not accept somebody making me suffer for their stupidity and their in unwillingness to do their job. I don't know what it is. It's like a gene I was born with, maybe on chromosome 26. But I have this, I turn into this Irish bastard when people try to make me suffer for their laziness or lack of willingness to fix a problem. I don't know why, but that's something about me. Now I've told you my my kryptonite story. Okay. So if you want to see me get angry, just don't do your job and make me suffer as a result, and then I'll get really, really angry. Other than that, I'm the nicest, sweetest little groundhog in the world. All right. What's going on with our irrigation? Are we still good?
Yes.
Mm-hmm. Good. Just lay still. We're almost done. All right. So you see why this second side is harder, Dr. Patel? Because of the bleeding from the first side. Yeah, it just goes right through the disc, actually. It's not bad. It's not like life-threatening bleeding, but it's, you know, obscuring the view. Luis, I need to be able to roll this. Your hand, the way it's holding it, is not letting me roll it. There you go.
Better?
Yeah. Understand something. Watch something. Let go for a second. Okay? Watch the loop. Let go.
Yeah.
Just let go. Everybody let go. Everybody let go. Watch what happens to the loop when I twist. What is the loop doing? Good. So when you hold it here and you're like, I'm not pinching it, I'm holding it, are you interfering with my ability to roll it? Yes or no?
No, sir.
Okay, watch. You're holding it here like this, right? Let go. I'm rolling it. Are you interfering with my ability to roll it? Yes or no? Huh?
No, sir. Not right
Somebody explain it to him, please.
now. Not right now, but I need to prevent this.
No, no, no. But if you hold it here, do you not see it moving? Let go.
Yeah, it's
Let go. Look. So when you hold it right there fixed, you are interfering with my ability to roll it. You following me? All right, good. I would rather, what your job to do, Luis, is not to prevent it from rolling or moving. Your job is to prevent it from becoming unsterile. So as long as it flip-flops around in the sky like a shooting star, it's okay. As long as it doesn't hit something that's not sterile, right? So your job isn't to keep it from moving. Your job is to keep it from getting unsterile. So as long as you understand that, you can let it move. Just don't let it get unsterile and contaminate the field. All right. So I apologize to our viewers who are seeing a blurrier view because there's a little bit of blood from the other side, which is, again, not bad for the patient, but it just makes seeing a little more difficult. So how can I continue to operate? Because if you think about it, I've done an average of 2.5 discs per patient, 900 surgeries of this type. So that's almost, what, 2,000? It's over 2,000 discectomies that I've done in my 13 years of doing Deuk laser disc repair. That's a lot. And the discs aren't that different. So I know the anatomy pretty well. I'm not saying I could do it blindly, but just I blindfolded because I cannot. But I can certainly deal with a little bit of blurry vision here. The main thing is don't panic. If you have a little bit of blood, no big deal. Just keep checking and making sure that everything inside the metal tube should be something that's not damageable, like a nerve or anything, you know? So keep checking to make sure the nerve hasn't snuck in there. If the nerve sneaks in there, you have to do something different. You're going to have to maneuver your tube and get it out of the way so you don't zap it with a laser. That would be like a great white shark sneaking into your beach. You don't just keep swimming. You have to deal with the great white shark first before you start swimming again. Otherwise, it's going to bite you. Please do. Just about done. 5 minutes. This is a bad one on this side. Look at all that. Grumba. Are we good? So the reason the bleeding has gone down a little is because I've collapsed all this soft disc around it, the hole where it was coming out. This has been a good case for seeing some things that are a little bit different. Once again, these are all live streams over the internet, so if you're watching this and your name isn't Zach, then you're watching it over the internet. If you're watching it over the internet, then you're seeing a live stream or you're seeing a recording. But if you're watching today, the 25th of April, 2019, you're watching a live surgery. And we don't edit our surgeries at all for content or neither video or auditory content. Everything is as is. So you get the good and the bad and the ugly. Can you wipe the tip, please? Thank you. The good is Luis. The bad is Dr. Patel. And the ugly is Dr. Deuk. Right? Oh, no, no. Just kidding. That's one of my favorite movies of all time. Just one of the best. So who gets it in the end? Anybody know who gets it in the end? Let's see who's a movie buff of Clint Eastwood. Zach? Let's see what
Yes,
our
sir?
audience says. Who gets it in the end? The good, the bad, and the ugly. Does the good get it? Does the bad get it? Or does the ugly get it? Let's see what our audience comes back with. We'll just do a little poll. All right, audience. Type your choice. The good, the bad, or the ugly. Dr. Patel, do you know the answer? Surprising. Stand by. We'll give another few minutes for people to get their answers in.
We had a viewer say the good.
All right, what I mean by gets it is who gets killed. Who gets their comeuppance. All right, you're saying the good.
And another viewer said ugly.
Okay, fair enough, fair enough. This is pieces of herniation I'm pulling out. You're saying ugly? What are you saying? Who's saying ugly? We have some ugly votes over there? Oh, yeah, he's not ready yet. He's medically ready, but I gotta go talk to him. He flew in from either Hawaii or Texas, I think. I think he's either from Texas or, huh? All right, have we got any more votes in?
We had the person who said good change it to bad.
All right, good, good. That's smart. Because that's the right answer. The bad gets it in the end. That's one of the things about the movie that's so beautiful, is even though the main plot is the good versus the ugly, almost the whole movie, in the end, both the good and the ugly know who has to go. It's the bad. The bad is just evil. Is evil, evil, evil. And they all know he needs to go. Besides, they also know their best chance of getting him is if they work together. So, all right. I guess you're right, though. The ugly does get it in a way, too. But in a way that he's not going to die, he's just kind of stuck out in the middle of the desert. Still with an opportunity to survive. Just the same way he left the good. So, great movie. If you don't know what we're talking about, The Good, the Bad, and the Ugly, it's a famous, we call them spaghetti western with Clint Eastwood. And these are movies when movies were movies. These are thinking movies, like really cerebral. You have to really understand the dynamic between the characters and what's going on. And they're not like a lot of the brainless movies we have today that don't take any thinking. So, if you get a chance, get it out. The Good, the Bad, and the Ugly. If you have never seen it, I think I've watched it about 7 times now. I never get tired of watching it. What was the name of what? The Grave? Oh, The Name on the Grave. I can't remember. I can't remember the name on the grave. I want to say there was no name, but for some reason. Right? Anybody know what was the name on the grave in that movie? Zach, a little movie trivia? Yeah. Thank you. Yeah, remember the ugly was running around trying to find the money? You know, kids these days have a name for that. They call it sweaty. Have you guys heard that term? Someone who's sweaty? It's so funny. Zach, are you familiar with the term sweaty?
Yes.
All right, so you're laughing. I don't know why you're laughing, but sweaty, my son says sweaty is, my son's 14. He says sweaty is like people who like really try super hard. And you want to know what's absolutely crazy funny? Is if you look at the ugly, he's always sweaty. He's always trying hard to get the money. And I wonder if that's where they get that term from. Because a lot of the younger generation describe people who try really hard as being sweaty. I never heard that growing up. That was not a term that we used. We never said somebody was sweaty because they try really hard. So I wonder if they're referring to the ugly.
We have a question.
Oh, yes.
We have you were asking, when you run tests on the herniated tissue that's removed, how often do you find disease or cancerous
Pink
tissue?
color? Look at the pink color. All right, so when we run tests on the herniated tissue, how often do we find cancer or diseased tissue? That's a great question. Thank you for asking that. I want you to look at what I'm looking at right here. You see how pink it is? That's all inflamed tissue. This is the outer annulus. It's severely inflamed. So when you ask how often do you find abnormal tissue, all the time. But that abnormal tissue is always inflammatory or arthritis. We never find cancer. Not once have I ever found cancer. So infection, tissue, cancer tissue, never. Abnormal, arthritic, inflammatory tissue, all the time. But never cancer. Great question. Thank you for asking. That's the interposed disc right there. So far, really good questions. All right, I'm just about done. I'm going to be wrapped up in just a minute. Maybe 2 minutes, actually, to be more precise. Was it John Carson? Maybe that's what it was. You're right, they were. Because of that guy in the beginning that was killed in his bed. No, maybe he was killed by the bad. Remember in the beginning? He was sick in bed and the bat snuck in on him, killed him. Wanted to know where the money, some money was. Yeah, please don't lose that. All right, this is the end of the crack. You can see the epidural space, end of this fissure. This is actually pretty bad, to be honest with you. Didn't expect it to be this bad, but you know what? Actually, I should. Remember when we did the discogram an hour ago? And the patient said, ow, where do you feel that? Down my right leg. This is the side of the right leg. This is where he felt it, right here. And you see all that inflammation I just cleaned out? All that red tissue? That explains why it's this disc, L45, that's causing all the inflammation going into his right leg. I'm convinced. So basically what I'm saying to you all is once we fix this, I think his right leg pain is going to be gone. I think his left leg pain is going to be gone. And I think his back pain is going to be gone. So I'm going to be curious to see how he does when he wakes up. But right now we're done. Last few zaps. And last bit of this herniation here. We're ready to shut it down. Are we out of irrigation? Because we're done. And the root is right there. You see the nerve root right in that fat? It's kind of hard to see, but it's bulging in. Okay, we're done. We're done with this case. We did bilateral L45 Deuk laser disc repair and left-sided L34. Scope off. Go ahead. You want to do it? And then pull it out and put pressure. Okay, can you do that, Dr. Patel? I'll take any more questions you have. I want to say great job, everyone. Really good case. It went very smooth. Thank you. And I'm going to go see the next patient real quick because he flew in from out of state. We're going to go talk, and then we'll be doing his case in about an hour, I hope, or tomorrow morning, huh? Yeah, we're going to go do a video right now in the recovery area. So follow me to the recovery area. We're going to turn this live stream off, I guess, and then we're going to pick up in 5 minutes in the recovery room and say goodbye to our first patient. She's going home, and she's agreed to be videoed.